The past speakers have been very elaborate in letting us know that INOCA or no significant disease except of the coronary microvascular dysfunction is now no more considered benign. We have a 5-year MACE including MI, stroke, and heart failure, close to 27% versus 9.3%. And many of the angiograms for suspected CAD, especially in the West, turn out to be normal in as much as 50%, and quite often even in India. So how do we go about assessing microvascular dysfunction? One way is to do the TIMI flow. TIMI flow grade 0 means no flow. TIMI grade flow grade 1 is there is penetration but no perfusion, so it will be very less perfused. TIMI grade 2 is partial perfusion, and TIMI grade 3 is we have complete perfusion, and of course there is a significant inter-observer variability and only 71% agreement when you have multiple labs, core labs assessing TIMI flow. So to avoid that, the Braunwald group found one way which was to measure the number of frames required for the dye to reach. So it would be the first branch of PLV in the RCA, or the most distal OM in circ, or the distal LAD bifurcation, which we call the whale tail. And because the LAD is larger, you divide it by 1.7 and you do it, count it in 30 frames per second sort of cine. And the CTFC or the corrected frame count correlates very well with the coronary flow as measured with the Doppler wire. The normal frame count is 21 plus minus 3, and the TIMI frame rates, if globally high in non-culprit vessels, higher mortality. That means there is slower flow. And if the CTFC is less than 14 after thrombolysis, it's an hyperemic and it's sometimes called TIMI grade 4 flow. You have a 0% mortality after thrombolysis in such patients. Despite a normal TIMI flow or a CTFC less than 40, a TIMI perfusion 0 has a 5% mortality versus a TIMI perfusion or a blush grade 3, which is less mortality, less than 1%. That means the capillary perfusion is doing well. So coming to the second way to assess microvascular dysfunction, it's to use the Zwol blush criteria. 0, there is no blush. 1, minimal blush. 2 is moderate, but which is less than the non-infarct vessel, and 3 is a normal blush. So it was used in the total trial. We know it's the aspiration for primary PCI trial, and a blush 28% 0 or 1 for thrombectomy versus 30% 0 or 1 for PCI. The mortality was quite similar. So in this trial, the blush grade was used to assess the coronary perfusion, and it was found that thrombectomy was not so superior in people with primary PCI. These are the types of coronary microvascular dysfunction to be: one is primary in absence of structural heart disease, type 2 is presence of cardiomyopathies, type 3 in presence of obstructive CAD. So you have microvascular dysfunction in 30-40% of people who have obstructive CAD, and after coronary interventions you may still have less flow despite opening up the obstructive CAD. And type 5 is after cardiac transplantation. And we need to remember that the capillary venules and the arterioles, pre-arterioles, are a structure which is as small as 40 micrometers, and the arterioles are 40 to 100. The large ones and pre-arterioles may be 200 to 500 and have different ways in which they are to be assessed, whether they are endothelial dependent or myogenic or metabolic is a different ball game at the level of obstruction we are seeing. So FFR works for the epicardial arteries. For the pre-arterioles to the capillaries, it's the IMR, and for the total you have to have the coronary CPF for the whole area. So these are the strengths and limitations of special diagnostic techniques to evaluate CMD. Non-invasive, the PET has a very high accuracy, reproducibility, but has a significant cost. The CMR, the Doppler echocardiography, especially for the LAD, can be assessed as a good diagnostic threshold and prognostic validation. The invasive are coronary flow reserve and IMR, and they have to be assessed invasively. So these are some of the algorithms. After an angiogram, you do a vasomotor testing or a CMD, and you need a pressure wire which is special to have a temperature sensor and a pressure sensor both. Unfortunately, Abbott is not promoting this in our country, but this is the way we can assess the IMR in the cath lab, and IMR more than 25 is considered significant. So if we look at the epicardial artery and microcirculation, then specific to microcirculation is IMR, FFR for the epicardial, and for the entire tree, the CFR. If you do a transplant, even then if your IMR is high, your death or is higher, so microvascular validation is important, and these are the ways to assess it. CFR, IMR more than 25, and these are the European Society guidelines. So guide wire based microcirculatory resistance is class 2A level, giving intracoronary acetylcholine with ECG monitoring during angiography if coronary arteries are angiographically normal or have moderate stenosis with a preserved FFR. To assess microvascular vasospasm is considered 2B, and transthoracic Doppler of LAD, CMR and PET may be considered, which is again a 2B indication. This is again based on the European Heart Journal, how to evaluate and the consensus guideline. And in conclusion, I would like to conclude and say that CMD in absence of CAD, which is termed INOCA, is a common problem with risk factors as for CAD. It can be diagnosed both non-invasively and invasively in the cath lab. A TIMI frame count is an easy and accurate way to define CMD. Thank you for your kind attention.